Welcome to our monthly Tango Alpha Lima Be the One podcast. I'm your host, Amy Forsyth, and I'll be here on the first of each month with guests who provide expertise, resources, and peer-to-peer support as part of the American Legion Be the One initiative to prevent suicide within the veteran community. On the first day of every month, American Legion family members are encouraged to wear Be the One apparel to publicly show their commitment to reducing the stigma around mental health issues. During this episode, we discuss topics that may be troubling for some. If you or a veteran you know is in crisis, call the Veterans Crisis Line at 988 and press 1. Go to betheone.org to learn how you can be the one to save one veteran. Let's get today's conversation started. Hi, everyone. Today, our guest is Dr. Craig Bryan, an Air Force veteran and board-certified clinical psychologist at the Ohio State University Department of Psychiatry and Behavioral Health. Dr. Bryan serves as the Division of Recovery and Resilience Director, a stress, trauma, and resilience professor of psychiatry and behavioral health, trauma program director, and suicide prevention director. Thank you so much for joining us today, Dr. Bryan. It's a real pleasure to have you, and we're really looking forward to hearing your story and all the work that you're doing with the American Legion and at the Ohio State University. Thanks.
Yeah, thanks so much for having me.
Let's get started by learning a little bit more about your journey. And you started off your career as an active duty Air Force officer, but where did you grow up and where did you go to school?
Yeah, so I was born and raised in St. Louis, Missouri, and moved around a couple places. Those who are from St. Louis or the St. Louis area will recognize I grew up in North County, and then we moved to South County, and went to school, high school at Smet Jesuit High School. And after that, after graduating, moved east a bit, went to the University of Evansville in Evansville, Indiana, majored in psychology. And once I finished my undergraduate degree, went and started graduate school at Baylor University in Texas. And that was soon thereafter kind of the entry point into the Air Force.
So you had already finished your graduate degree, then you entered the Air Force. Was that something that was on your plan and as part of the overall plan from an early age?
So no, I do not come from a military family. My cousin was in the Missouri National Guard. My uncle served in Korea. My grandfather was in the Pacific in World War II. But we didn't have, that sort of traditional like military family that we often think about. So it was totally off my radar, early in life. And it wasn't until 9/11 happened. That was my final semester of college. And at that time, I just had one class left to graduate. And so I was working graveyard shifts, providing care for autistic adults who needed assistance. And so I got off work at like 6, 7 a.m., went home and fell asleep, and then woke up and, everything had changed. And so going into graduate school, then very soon thereafter, one of the very first classes that I took, our instructor been alive during Vietnam, during Korea, and on the morning of the invasion of Iraq. I kind of paused our class before we got started and said, let's talk about what's happening in the world. And his concern as a more senior individual was because I've seen what happens in war, and you will be psychologists someday. You have a role to play in helping those who will bear the cross that comes from war. And so I want us to just reflect upon this for a moment and what this means for you, but also for a nation. And I think, in retrospect, I don't know that I recognized it then, but in retrospect, that I think probably was where the first idea of military service came to mind. And it was over the next few years of graduate school. My training director, David Rudd, who's also a psychologist and is active in the Legion as well. He served in the Army, and he really encouraged me to look into the military. And so a few years later, I commissioned to finish up my clinical training and become a psychologist. Get my payback and commitment after that. So that was kind of my unusual journey of getting to the military.
You grow up watching movies thinking, well, I'm not a soldier, I'm not carrying a gun, and I'm not going to war or a tanker. But your role is so important, as you found out through your service and post 9/11, especially more needed than ever before, probably in this modern era. And so from there, you joined the Air Force, and I read in your bio here that you even deployed to Iraq, to Balad, Iraq, Balad Air Base, of course. A lot of combat trauma went on there for sure. But talk to us about your active duty service, and then when you decided to make that decision to leave active duty and then pursue staying in the military environment, which was so important.
Yeah, so I commissioned in 2005 and was initially stationed at Wilford Hall Medical Center in San Antonio at Lackland Air Force Base. The first year, wrapped up my pre-doctoral internship and, then received the doctoral degree, and then was retained there at Lackland Air Force Base to continue working as a staff psychologist. And I initially worked in Kelly Family Medicine Clinic and an integrated primary care setting. So it's kind of interesting because, it wasn't the classic, like outpatient psychotherapy that you think of for psychologists. It was, very brief, very targeted interventions, 20-minute appointments, high volume, and it was very influential for work that came much later on, very rapid acting, very to the point, effective interventions. And I worked there basically for 3 years on active duty. And then towards the end of my active duty commitment in 2009 was, when my turn for a trip overseas for deployment came up. And it was at the end of my commitment, so I actually extended, beyond my contract, so I could complete a 6-month deployment to Iraq and went to Joint Base Balad at the Air Force Theater Hospital. So I ran the traumatic brain injury clinic there, worked in the hospital, and that was, I think for sure, my deployment. That was another major turning point for me in my career and had a very profound influence on the work that I've done ever since.
Can you describe that impact it had on you serving in Iraq at that time? How did you come back, and how did you change as a person, or your perspectives change after that deployment?
Yeah, I think when I think of how I changed as a person, I mean, I kind of feel like I was able to understand much more clearly a lot more of what, my patients had been describing to me, other service members who had come back from deployment and their experience of that and what they would relate to me as a healthcare provider. Just being able to read between the lines and understand what they were talking about in a very, very different way. That was certainly a major change. But I think another big change was really, from a professional standpoint, it was while I was deployed that I really started, I think, second guessing a lot of our assumptions about suicide, about PTSD, and I think in particular, there are a couple experiences, but number one of which is like on the PTSD side, when you're in a combat zone, we don't have the luxury of like scheduling weekly therapy appointments, right? If you're struggling with like combat stress. And so myself and other psychologists who were deployed, we were doing these sort of out of the box ideas or people were getting blown up and we were treating them. And, we were very aggressively, like multiple times per day, every day, doing therapy sessions, just saying, I can't meet with you every single week for 3 months. And so I'm just going to cram everything I can into as short a period as possible. And it was working. It was sort of mind blowing. And many of us brought those lessons back to the States. And now the concept of what's we refer to now as massed trauma therapy, where you do the therapy in 2 weeks instead of spreading out over months. That's like a thing now. And that came from the battlefield, where many of us were really just trying to do the best that we could to help others. And lo and behold, we discovered something that I think now has significant implications, not only for veterans, but for all of society. I think the second real change for me was that questioning of our assumptions of suicide. And it was because for me as a mental health professional who's kind of interested professionally in the issue of suicide, I'd worked with plenty of patients who had struggled with suicidal thoughts, who had attempted and survived suicide attempts. But the thing that I realized when I was deployed was that when people die by suicide, it happens at home, happens somewhere else. But in Iraq, I came face to face with the reality of suicide. I mean, it was the first place I'd seen dead bodies, and particularly, self-inflicted gunshot wound. The viciousness of it, the real brutality of suicide. It took on a very new meaning to me, and it was very transformative. And I can see now in retrospect that my career as a researcher, as a clinician, really took a turn at that point. And all of the work that I've done the 15 years since has been very much influenced and shaped by what I saw and what I experienced downrange.
Yeah, indeed. It does change you forever, and what you're seeing and hearing and interacting with people in just a different way. And so from there, but you decided to leave active duty. Was that the plan all along?
My plan when I joined the military, I had some good mentorship from more senior officers, but also senior enlisted, like our superintendent, our squadron chief, who sort of collectively said, you always take it one assignment at a time. And I remember one of the chief master sergeants that we had in our squadron, who, that was kind of her advice, was just like, as long as the Air Force is treating you well and you're doing important stuff and your family's taken care of, then stick with it. And but if it's not working out or you don't feel it's a good fit, you've fulfilled your contractual obligations, and people will choose different pathways. And so that was kind of how I viewed the opportunity. And so at the end of my 4-year commitment, other avenues, opportunities came up, and it was at that point to move into more academic university-based system to really start researching, developing, and improving treatments and therapies for suicide prevention. And that was really what I wanted to do. So it's nice because those were DoD-funded efforts. I sort of had this opportunity to make a switch in my career trajectory while also maintaining a connection to the military community that was so important to me.
And now you find yourself in Ohio at the Ohio State University. That just must be an amazing experience.
Mm-hmm. Yeah, and the interesting thing about this, I tell like students and other like postbacks who are thinking of becoming a psychologist, they always kind of ask me, well, how did you get to this point in your career? And I like to joke, it's like I'm the accidental psychologist researcher. I'm not supposed to be here. And what I mean by that is when I went to graduate school, I went to a program that was very much focused on training clinicians. My degree is a PsyD as opposed to a PhD. And so it was in essence this course I took of being a clinical care provider, health services provider, rather than being a researcher and a teacher. And then, yeah, here I am 20 years later, and I never would have predicted this is where I was going to be, where I'm leading research studies, kind of thinking of, well, what do we need to do next? How do we improve upon this? But all of that, getting to the sort of researcher part of my career was directly informed by the work that I was doing in the clinic. And it was the patients sharing their experiences with me kind of connecting with them and helping them through these processes that, started stimulating within my own mind. How can we do this better? How can we help more people? How can we, improve the effectiveness of our interventions? And pretty much all the research that I've done ever since then have really been driven by that desire.
Well, and the wonderful thing here at Be the One podcast is that we've had the chance to connect with so many people, whether it's in research or publishing books, and those working with foundations and fundraising for all kinds of ways to prevent veteran suicide. And so, what are some of those core competency, core missions? And you've partnered with the American Legion to really move the needle in terms of the research that's needed, or finding ways and connecting the dots on how to reach those veterans who need help the most. And how have you been able to kind of like work with the folks at the university, and then also with the American Legion?
Yeah, I would say there's sort of two areas where we've, I think, been able to do this, and they both relate to the broader goal of preventing suicide and promoting well-being and health amongst veterans. The first of which is developing, testing, and improving treatments for service members of veterans who are struggling with suicidal thoughts and who've attempted and survived suicide attempts. 15 or so years ago, when I first got out of the military and moved into academia, was when we conducted our first large-scale research study to test a psychotherapy to prevent suicidal behaviors. And it took several years to finish that, but what we found in the end was that, yeah, this therapy that we had, we found reduced suicide attempts by 60% as compared to the typical mental health treatments that we were offering in the military. We then, did follow-up research to look at different pieces of the intervention. We've again, we showed in subsequent research that we could prevent now 76% of suicide attempts. And so we've continued to build on that as we go, because even though these treatments that we've developed are incredibly effective, they're way better than how we used to treat suicide risk in the mental health field. There's still a subset of people who attempt suicide despite receiving the therapy. And so that's a big part of the research that we're doing right now. It's like, well, why? Like, are we not hitting the things that matter the most? Do we need a second therapy that, kind of complements the first one? Do we need a bigger dose of the therapy? Those are the types of questions that we've been asking about. And so that we can now move the bar a little bit more from 60-70% reduction in suicide attempts to 75%, and we want to get to 80%, and we'll just keep inching our way forward systematically. So that's one of the big areas we've been partnering with the American Legion, is helping veterans become aware of our research studies and projects. We enroll veterans into our studies so they receive psychotherapy at no cost. And in exchange, we're able to understand the therapies better, to figure out ways to make them work a little bit more with more oomph or more potency. The second area that we've been increasingly focused our attention on, also related to suicide prevention, is getting much more upstream. What I mean by this is that we know that over half of service members and veterans who die by suicide are not engaged in mental health care at the time that they die. And we also know that they do not have a mental health diagnosis or a mental health condition like depression or anxiety or PTSD. And so it's going to be really hard to prevent suicide if we only think about developing and testing mental health treatments. We need to get outside of the healthcare system to reach the half who are not coming to our hospitals and clinics. And overwhelmingly, that group that does not come to treatment, those veterans astronomically are more likely to use guns to kill themselves. And so a big part of our research now is really focusing on how do we prevent suicide amongst veterans who do not have a mental health condition, do not access care, but they own guns. And so we've been focusing a lot on secure storage practices and encouraging veterans to use lock boxes, safes, or whatever other secure storage method they feel most comfortable with. And some of our research has suggested that first and foremost, veterans are actually very receptive to this. When we first started this line of research years ago, the general consensus, there's no way veterans will ever want to talk about gun storage and gun safety in this way. And what we have since learned is actually veterans are leading, I think, the nation in this area. They're much more willing to talk about firearm safety, and they're much more open to the idea. And so we're starting to now see that very simple things like how you lock up your guns at home could actually be one of the big missing pieces for suicide prevention in the veteran community. And the American Legion has been a very welcome partner in helping to disseminate that information and to get veterans to help other veterans to ask that question about secure firearm storage.
I saw that being mentioned at a recent event at American Legion. So I was that makes sense to the origin of it. And so I think that any and all solutions are on the table. What's your take, or what are your thoughts on some, alternative therapies or the psychedelics, moving in that direction? What's been your thought or your experience with that?
Yeah, I definitely get asked about that a lot. And we have actually some researchers here at the Ohio State University doing psychedelic assisted therapies to see about the viability, effectiveness of those treatment approaches. I'm a person who's driven by science when it comes to these sorts of things, and along those lines, I think it's sort of too early to say for sure. I think psychedelics, are still very, very much an experimental approach. And so it's one of those things where I say only time will tell, but I do think there are a couple of pieces of advice that I usually give to veterans when they're thinking about this. The first of which is we have access to a number of more I don't want to say they're status quo treatments. They're new psychotherapies, but they don't involve medications. They don't involve psychedelics, things like that. But they're sort of newer iterations of treatments that are incredibly effective. And so the good news is that if you were to pursue some of these non-psychedelic related treatments, there's actually a really good chance that they'll be beneficial to you if you give them a chance, you fully engage with them. Then the second part is the second piece of advice is that I always recommend to veterans say, maybe you try out one of those things first. And if these other non-psychedelic related interventions prove to be unhelpful, they're not beneficial, that's where we would perhaps want to start considering options for engaging in more experimental treatments in the same way that we approach almost every other health condition that we know of, where we start with the best available treatments, and then it's only if a person continues to struggle afterwards that we might start moving into the more experimental therapeutics. And that's because we just don't know a lot about the experimental treatments, including side effects, risks, benefits, all that kind of stuff. And so there is a bigger risk associated with them.
Sure. And then how about the VA's adoption of those, or the VA's moving forward in terms of helping veterans? Where do you stand on, their level of care for this?
Yeah. One of the things, it's kind of surprising to most people to hear this, but there have been independent reviews of VA care quality. And what has actually been found multiple times by external agencies is that on average, the VA provides better care to veterans for mental health issues than private sector, the community. Now, there are always exceptions to the rule, right? And people have different experiences, but just as a group, as a whole, what seems to be the case is VA provides a higher level of care than what we get outside the VA. Now, one of the recent trends within VA is to open the door for researching some of these more experimental methods. And so I think that's good, because we do know that even though, again, we have some treatments that are incredibly effective, not everyone benefits from it, and we don't really know why. And so being able to do that research to understand, if someone does not respond to the more conventional treatments, what are the backup plans? What is plan B? What's plan C? I think that is absolutely the way to go. And that's where I think some of these psychedelics and other newer experimental therapies may be able to help some veterans who have not been able to benefit from, the more traditional classic suite of options available to us.
And partnering with nonprofit organizations such as the American Legion, have you found that is an effective pathway forward, and why the American Legion in particular?
Yeah, I mean, it's incredibly helpful for a number of reasons. One of which is because when we're doing studies and programs directed towards veterans, being able to partner with national organizations with, very large memberships, very large rosters, sort of gives you like direct to consumer access, so to speak. And so in our case, we're researching and trying to develop new treatments to help veterans. And so being able to partner with the American Legion to, inform, millions of veterans, here's an option, here's how to access it, increases the likelihood of veterans being able to learn about these projects, but it also accelerates, the speed with which a researcher like me can come up with answers. One of the hardest parts of doing high quality research to develop treatments is recruitment, finding people willing to volunteer their time to do it, because it can be time consuming to go through therapy, to do extra assessments and interviews. Even though we pay people for doing that, it's still a time commitment. And in many of our studies, in order to see if a treatment works, we're usually flipping a coin. Like, we decide the treatment based on whether you get heads or tails. It's the only way for us scientifically to really be able to say definitively treatment A is better than treatment B. And so what that means is when people volunteer for our studies, we hear this from veterans all the time. They're like, I may not benefit from this, because I might get tails and not heads. But I know that my participation in the study, it's not just about me, it's about every other veteran who's struggling like I am. And if it helps someone else, even if it doesn't necessarily directly help me, then that's what this is all about. And so it's just, and I have found, working with my fellow veterans around that, veterans have that mindset so much more than civilians do. And so it's, in that sense, much more rewarding, and part of the reason why I continue to work with veterans so many years after getting out of the military myself. There's a sort of willingness to contribute for the greater good of the community.
And what's on the horizon for you in terms of what big projects you're working on, or what in the coming years, what's on your horizon?
Yeah, so our team at the Ohio State University, our team is collectively referred to as STRIVE. So STRIVE stands for Suicide and Trauma Reduction Initiative for Veterans. And there's two areas of focus: suicide and trauma. We have at any given time amongst our 8 to 12 researchers around 40 research studies, just looking at all of these different ways to prevent suicide, to help with PTSD, traumatic brain injury, things like that. And so one of the big studies right now that we're working on is actually funded by the Department of Defense, and was really motivated by the DoD wanting us to confirm our previous findings from that earlier study I was talking about, where we developed a new therapy that reduced suicide attempts by 60%. The DoD said, that's amazing. Can you do it again? And can you do it with a bigger group of people, so that we have greater confidence that we're picking the right treatments? And what's unique about this new study is that we're pitting head to head two competing psychotherapies, both of which have been found to reduce suicidal thoughts, to reduce depression, anxiety. And one of the things we anticipate is maybe one therapy will be better than the other. We definitely want to know that, but we also suspect that each therapy may be better suited for different people. And we want to start matching. So when a veteran in the future comes in the door, we can maybe ask them some questions about what they're experiencing and say, hey, we've got like 2 or 3 options, but this is the option that's probably going to be best suited for you. And that, I think, is the ultimate goal of the current research, as well as where our team is heading in the near future, to personalize the options so that people get better faster.
Not one size fits all for sure.
Right.
That old model of treatment.
Yeah.
Yeah. And so if people want to learn more, or what advice would you give for our listeners out there or viewers today about the research you're doing, about what basic tips or advice you would give if someone's on the fence about seeking help or trying to be a part of a study? What would you say to them?
Yeah. Well, I'd say if listeners are interested in potentially volunteering for one of our research studies, they can certainly reach out to us directly. We have a easy to remember website. It's just strive2be.org. And the two is the number two. So strive number two be.org. Or they can reach out to us via email, strive@osumc.edu. And just say, hey, I've heard about your research and think I might be eligible. I'd like to learn more. Some of the most common questions that come up when service members and veterans reach out to us about this is they're often worried about privacy restrictions, what happens to their records, things like that. And so we can walk them through that process. Because it's a research study, we're not necessarily keeping medical records like they would under other circumstances. We get a lot of questions as well about does someone have to live in Ohio to enroll in our studies? And not necessarily. A lot of our studies now, ever since COVID, we've gone almost entirely virtual. And so many of the veterans receiving therapy on our research studies are from all around the United States. And so we're typically able to accommodate time zone differences, work schedules, things like that. And then I think the other question that is frequently asked is, kind of, well, what happens after the study is done? And what we usually find, most of the veterans who complete one of our research studies, they find that once they're done with the therapy that is being delivered, they find that they don't need any more therapy. So some of them just kind of wrap up at that point, but others will help connect with follow-on care. Sometimes it's through the VA. It's also through other community partners and agencies that provide high-quality services to veterans. And so we try to do whatever we can to help the veteran, meet their needs within their local community so that they can continue to to grow and to achieve well-being in their lives after participation in the study.
Well, thank you so much for sharing all of this. And your final message for folks out there listening or watching, what would you like to share with them?
I'd say my final message, to repeat a point that I made before, is that we are getting better and better at treating suicidal thoughts, PTSD, and so there's a lot of hope in improving your well-being and quality of life. And we'd be happy to talk with any veteran or service member who wants to learn more about our projects and see if there might be a way that we can help them.
Wonderful. Thank you for sharing that message. And today's guest, Dr. Craig Bryan, an Air Force veteran and board certified clinical psychologist at The Ohio State University Department of Psychiatry and Behavioral Health. Thank you so much for joining us today. And we look forward to hearing more down the line as more research is done and results, and really moving the needle to help reduce veteran suicide for sure. So thank you. And thank you, Alphas, for tuning in to the Tango Alpha Lima Be the One podcast. Remember, you can be the one to save one veteran. Find resources and more information at betheone.org and connect with the American Legion on social media to keep the conversation going. Don't forget to subscribe to the Tango Alpha Lima podcast on YouTube, Apple Podcasts, Spotify, or wherever you find podcasts. And please share our podcast with others. And we look forward to seeing you on the 1st of next month. Thank you so much. On the first day of every month, American Legion family members are encouraged to wear Be the One apparel to publicly show their commitment to reducing the stigma around mental health issues. Go to betheone.org to learn how you can be the one to save one veteran. If you're a veteran in crisis or concerned about one, call the Veterans Crisis Line at 988 and press 1. You're not alone. The Veterans Crisis Line is here for you, and you don't have to be enrolled in the VA. Help is available, and speak with someone today.